Okay guys, so I know there was a lot of issues with people being able to open the first endocrine lecture, so I'm going to try and do it this way. I'm not sure how well it'll work, but we'll try it. So, see, I can't even get my computer to work now.
So here we go. Okay, moving right along. Pituitary gland. So the pituitary gland also has this other name, but we never call it that, so just remember pituitary gland. So it's again the master gland. That is, pituitary is actually where most of the hormones actually come from. So it's the little guy with the packs a big punch. It's one of the smallest glands, but like I said, it's got probably one of the biggest roles in the human body related to homeostasis and keeping us healthy. If that's not healthy, we're not healthy. Let's see. And then I already gave you a list of all the hormones, and but here's another list. Again, you'll have them in more than one place, and what they comes from the anterior and posterior lobes. And you can read the rest. I already went over some of this already. So posterior pituitary. These are the first two disorders we're going to talk about. Diabetes insipidus and syndrome of inappropriate diuretic hormone. Both of these disease processes have to do with fluid, okay? Fluid in our body. So you need to tell them apart. You will need to understand what hormone is the one that's responsible for these disease processes, which is ADH, antidiuretic hormone. That's the hormone we're working with these two diseases. ADH, antidiuretic, otherwise known as vasopressin. Okay? You'll hear vasopressin in your practice because it's also a medication, considered a medication that we give when a person cannot maintain a blood pressure. And you'll hear it again when you get to critical care, when you get to CHA2. You'll be given vasopressin to your crashing patients that are hypovolemic. So, but for your purposes today, vasopressin is the culprit for diabetes insipidus and SIAH. Okay, so first of all, the word diabetes insipidus. When we hear the word diabetes, most of us automatically think sugar, right? Because we have all been ingrained in our heads that diabetes means blood sugars. Actually, the term diabetes itself is a Greek and Latin word that actually means excessive discharge of urine. That's what the word diabetes actually means. Okay? So diabetes insipidus, the insipidus word means tasteless. So diabetes insipidus, I know that sounds horrible. Tasteless urine? No, that's not what I mean. What I mean by tasteless in this case is a lot of urine that's not being filtered. Okay, so tasteless. There's nothing in it. A lot of urine with nothing in it. That's diabetes insipidus. Okay? So just because that's what we're talking about right now, diabetes mellitus, the mellitus in diabetes mellitus with sugar, mellitus means honey sweet. That's where that word came from. So all these weird terms we have for medical diseases, somewhere back in the day, these Latin and Greek people and physicians that came up with these diseases, the words just stuck. So diabetes insipidus has absolutely nothing to do with sugar. It's got everything to do with fluid. Okay? So that's what you need to know. And it all has to do with the hormone ADH. Again, you can see where it's regulated from. And ADH tells the kidney to either hold on to water or get rid of it. With diabetes insipidus, there is an insufficiency of ADH. Okay? There's not enough ADH. Not enough antidiuretic hormone equals too much pee, too much urine. Okay? So I also said that the urine is going to be tasteless or nothing in it. So remembering from the renal system what a specific gravity is, do you think a person's specific gravity would be high or low with diabetes insipidus? Low. Absolutely, low. Very good. Because you're not filtering anything. There's nothing in the urine. Specific gravity shows you that your kidneys are filtering, right? If it's not filtering and there's nothing in the urine, the specific gravity is going to be next to nothing, really, because there's nothing in the urine. It's just fluid. It's just water, okay? So with a patient with diabetes insipidus, their specific gravity is typically less than 1, or at 1.005 to be specific. But if it's close to 1, you know that, okay, they've got a problem, okay? Their ADH is probably way off whack if their specific gravity is low. Okay, so diabetes insipidus, moving right along. Again, polyuria is one of the symptoms, extreme thirst. Also, hypernatremia. So this is something that you will hear over and over again in your nursing practice and nursing career, is hyper and hyponatremia. With diabetes insipidus, it's hyper. Now, we're losing fluid, right? So, in other words, our sodium is going to be high because it's more concentrated in our circulation because of the lack of fluid. So hypernatremia. The less fluid we have in our circulation, did I say that right? Yeah. The less fluid we have in the circulation, the more sodium there's going to be because it's concentrated. Okay, does that make sense? It needs to make sense because this is important. You'll hear. And so in other words, if you have, well, for instance, the next disease we're going to talk about is syndrome of inappropriate diuretic hormone, where there's too much. So if you're retaining fluid, if you have too much fluid, what is your sodium going to be? You're going to have low sodium because it's more diluted, right? So the more sodium you have, the more fluid you have in your system, the lower your sodium will be. With diabetes insipidus, you have less fluid in your system, your sodium is going to be high. I want everybody to just think about that. What I do sometimes is I draw a picture. Again, me and my visuals. But I'll draw a picture. Like this is our circulation. Okay? This is hypo or low sodium. And the reason it's low sodium is because the rest of that is full of fluid. Okay? And this is hyper or high sodium because there's no fluid in there. There's more room for the sodium. Okay?
So didn't you say, though, with diabetes insipidus, there's a lot of fluid? Or didn't you say there's less?
Diabetes insipidus.
Because this has, regulates body. Okay, never mind.
Yeah, that's just telling you what the hormone does.
Okay,
Yeah, the first paragraph there under diabetes insipidus is simply telling you what the hormone ADH does.
Okay.
That's all that
There's a
is.
lack
Yep.
of it, so, okay.
Yep.
All right, thank you.
Yes. Another
So
question?
Is your salt content actually that much higher, or is it due to the, like, when you're testing it, is it that much higher, or is it because that there is no water in there?
Well, it would read higher, yes. It would read higher. That's why it's hypernatremia. And so what do we mean by that? So a normal sodium is what?
135.
Okay, 135 to 145 is a normal sodium. So what constitutes hyper is, of course, anything greater than 145. What is deadly, or when is it going to be very toxic and dangerous to our patient? Well, that didn't come out very well. Is if it gets greater than 160. That's when it's going to be very dangerous for the patient. Okay? And then hypo, when it gets less, then usually in the 120s, that's when it's when it's dangerous for the patient. Okay? So a body is pretty good at compensating in between those two numbers. But when it gets above 160 or below 120, that's when the patient's really in jeopardy. Okay? So in other words, with diabetes insipidus, what is one of your nursing interventions going to be? Checking the sodium, right? Lab work, making sure that you know what the sodium is on your patient, okay? Making sure that we keep track of that. Okay, so this one's going to come back and get you in every class, pretty much every CHA 1, CHA 2. It's going to come back with a lot of diseases, the hyponatremia. So you need to really kind of get that wrapped around your head. Okay. Diabetes insipidus. Okay. Neurogenic. Okay, then it tells you how it can happen. Again, here I said head trauma. Again, remembering that the pressure on that hypothalamus gland affects the secretion of hormones, bottom line. There's other reasons. You can read the other reasons for it. And going on again to the symptoms, biggest thing that you're going to see is hypernatremia, the high sodium, the polyuria and polydipsia, and obviously high urine output. We're talking high. When I say high, I mean like greater than thousands. I mean, we're talking like 5,000 to 10,000 milliliters of urine a day. I mean, it's not a small amount. Diabetes insipidus is very, very large amounts of urine. It's pretty obvious there's something not right. And then also a lot of times the person craves ice water or water. I mean, it's like they just can't drink enough. And obviously because their body's trying to keep up with this lack of fluid. So they are very thirsty and obviously peeing all the time. What other, does anybody know, even though we haven't talked about it yet, what other disease process mimics this?
Hypoglycemia?
Hyperglycemia, absolutely. So we're going to talk about the polydipsia, polyuria, again, when we get to diabetes type 1. Again, see, the endocrine systems mimic each other with the signs and symptoms. Yes?
Are you going to see lower blood pressure in this, or not so much as the body fixing that?
Low blood pressure? I guess it really just depends on if they're able to keep up with the loss of fluid. So it just really depends on that, if they're able to keep up with the loss or not. It's not one of the main symptoms you're going to see, no. Okay, so then more on diabetes insipidus. They do a water deprivation test, and you can read what the water deprivation test is here. Again, we talked about alcohol already, and when we talked about the renal system, we're going to bring it up again here. If a person drinks alcohol, it reduces the ADH hormone secretion, and again, alcohol causes diuresis, so they're just making the problem worse. Okay, so again, alcohol, encourage people to avoid it if they're dealing with diabetes insipidus. So therapeutic measures, what are we going to do about it? Well, first of all, we're going to give them fluids. We're going to try to replace what they're losing. And with any time we're trying to assess a person's weight, we're going to weigh them. Okay, very basic. We're going to weigh them daily. We're going to monitor the urine output and the specific gravity, which we've already talked about. And like you asked, it was a very good question, Tyler, about blood pressure, we're going to check the blood pressure and the heart rate because that will tell us if they are getting hypovolemic. If they are losing too much fluid and their body's not able to keep up with that, their blood pressure is going to drop and their heart rate will increase. Okay, so we're going to keep an eye on that to see. See, with these diseases of the antidiuretic hormone, you're watching for both. You're watching for hypovolemia and you're watching for hypervolemia. This person can lose fluid and they can retain fluid. It could go either way. So you're watching for both. Okay, so as far as diabetes insipidus, let's see, we talked about this already, what we're going to watch. We talked about electrolytes, specifically sodium. Don't forget your other electrolytes too, like your potassium and your chloride and that. But sodium is really the biggest one with this particular disease process. Let's see. Did I have? Yeah. And then if we did give medications, we would give vasopressin. Because what is vasopressin? It's antidiuretic hormone. It will hopefully prevent the body from getting rid of all that fluid. And luckily we have it in synthetic form in this day and age, and we can just give it in an IV and hopefully fix the problem. This is just another little picture that might help you understand it if you're a visual learner. Okay, so the next disease process of the posterior pituitary is what we call syndrome of inappropriate antidiuretic hormone. This is the opposite of what we just talked about. Okay? Opposite meaning there's too much of the hormone ADH. So we have the opposite problem. This patient is retaining fluid. Okay? This patient's urine is going to be what? High concentrated. Very good. Their specific gravity is going to be high. Their urine output is going to be low. So everything we assessed on the diabetes insipidus patient is going to be the opposite on the syndrome of inappropriate antidiuretic hormone. Okay? It's the opposite. So the sodium in this patient is going to be what? It's going to be low. Hyponatremia. And what do we expect the weight of this person to be? High. They're going to gain weight because they're retaining fluid. Okay? Sometimes you'll hear it called water intoxication. So if you've ever heard that before, that is one thing that they call this. And a lot of times it's just simply abbreviated as SIADH. So SIADH is usually how you'll hear it in a critical care setting. Nobody has time to say, yes, this patient has syndrome of inappropriate antidiuretic hormone. We could have given the vasopressin in the time it took us to say that word. So, so we're saying SIADH instead. Okay, so what is it? You can read the slide here of what it is, exactly what's happening. Biggest thing, low urine output, fluid volume overload. Patient is going to gain weight. Their sodium is going to be low. Let's see. You're thirsty, like down here it says the brain says drink, so you're drinking, but the body doesn't get rid of it. Your body's not excreting it. It's not that the kidneys aren't working. That's not it. It's that the hormone ADH, again, the communicator is not communicating, hey, by the way, buddy, get rid of that fluid. It's not communicating that, so it's not doing it. Kidneys are fine. It's just not getting the message. Okay, so this is not in any way a problem of the kidneys. See, you see how hard it can be to diagnose these things? Because when you think fluid and inability to secrete, you think kidneys, but it's not.
Treated, then can it be a kidney problem?
No, if it's not treated, the worst thing is that the person will probably die of hyponatremia. Pretty much is what they can die from. I have a couple questions here in lacrosse. Yes, Tyler.
Going from what you said, so this is excess, so you said that the kidney's not getting the message.
Mm-hmm.
Or do you mean that the kidney, if it's obviously getting too much, that, I guess what you said versus what the slide says, because it's an excess, so to me, it doesn't make sense that the kidney's not getting the message. You know,
It's not, because remember, the hormone is released by the pituitary gland. Okay?
Right, so where are they getting lost?
That's the disease. It depends on what is causing the disease. Is it a medication? Is it whatever's causing the disease is where that message is getting lost. It depends on what the diagnosis of the patient is that's causing the symptom of inappropriate diuretic hormone. So this is a syndrome that's usually caused by another disease. Okay? So when hormone, like I said at the very beginning, hormones are at the mercy of organs that are working. But if there's a breakdown somewhere in one of our endocrine organs, there's going to be a breakdown of that communication. I can't answer the question of where is it occurring, because unless I know exactly what patient we're talking about and exactly what disease process they have, I don't know. And again, you remember how I said the endocrinologist spent 14 years in medical school? That's the guy you want to ask. Yeah. Mm-hmm.
Well, I'm just confused because if you have an excess and then you have too little, what's going through my mind right now, the too little's not making it there and the excess is not making it there. How do you have two different things going on?
They're two, are you talking about diabetes insipidus and this one?
Yeah.
They're two separate
I
problems.
understand that you have an excess and then you have too little.
Mm-hmm.
But I guess the way you're explaining it to me isn't making... You get what I'm saying? If you have an excess in the body and then you have too little...
But they're causing two different problems. They're causing two... Okay, yeah, I want you to, I do. Like I said, as I'm reading, as I'm giving you the diseases, and if how I'm explaining it doesn't make sense to you, you bought a $150 textbook that I want you to go back and read, and that will hopefully help you explain it. If I'm not explaining it better for you to understand, I have very little time to try to explain it. So if I'm not getting through to you, please, please use the resources. And I think we have some, there's well, actually the articles we have posted I think are on thyroid problems. But please read through your book, and if you're still not understanding it after you read the book, please then come and ask me about it, because I want you to understand this. But just know they're two completely separate diseases, and one causes too much, one causes too little, and the communication from the hormone from the gland to the organ it's supposed to work is getting lost somewhere.
I just have a simple question. So more of us are probably familiar with like diet and lifestyle causes of diabetes. Is there a diet and lifestyle attribute that goes with this syndrome?
No, there is not a diet and lifestyle with this particular syndrome, because again, a syndrome is something that is caused by something else. So in other words, this usually occurs in critically ill patients that have a lot of other comorbidities going on at the same time.
So it's not like 20 years of not exercising?
Correct. No, this has nothing to do, no, it's totally different than...
Something linking?
Nope. It does, that's a good question, but nope, it does not have anything to do with that. Okay. Okay. Any other questions? Do you guys, I don't know where you're at with your NCLEX stuff, but, or not NCLEX, I'm sorry, ATI stuff, but when, I'm like, I said NCLEX because I'm sitting here looking at my NCLEX book. But anyway, when you're doing your ATI stuff, under ATI, when you're doing your tests, you know, the quizzes for ATI, there should be some, like when you didn't have yeah, you did. You had an endocrine test. Were there any questions on that test related to these SIADH? Okay. So, Yeah, I guess sometimes I haven't really mentioned this, but sometimes what I encourage students to do is write down some of those questions that you're taking on ATI, because that is actually really good learning tools to study for the test. Like I said, we utilize ATI a lot as a template for our test in our program. So it's not a bad idea to, if you don't understand a certain disease, what kind of questions is ATI asking you about them? Because that's really what you need to know about it. So remembering that too, taking a little time with your ATI test that you take and writing down the things that you really don't 100% understand, and those are the things you want to be looking up as well. So, yeah, this isn't easy stuff, guys. This isn't. Like I said, we're learning a little bit about a lot. And it's hard, and there's a lot to it. But I'm trying to make it as easy as possible, but I know even that, there's just so much. And I'm apologizing. And if you have questions, Black River, and I see somebody with one, please ask. Yes?
Okay, so let's say with inappropriate antidiuretic hormone.
Yep.
So you have too much antidiuretic hormone, so that decreases the sodium because it's excreting that in the urine and is also making the concentration of the urine higher.
Yeah, but
it's causing the concentration to go higher.
Well, one of the major reasons why you have hyponatremia with SIADH is because there's less volume in your circulation and the sodium is more diluted. So when you do a lab draw, it's more diluted and it's going to be higher. It's more, or I said it's concentrated. I'm sorry. It's more concentrated in the blood. And so you're going to have a lower level because it's more concentrated. In the other disease, diabetes insipidus, that's when you're going to have it more diluted. Like that picture I drew. I don't know if that picture did anything.
Yes, that makes sense.
Okay. Okay. So in other words, yeah. So hypo, this would be your syndrome of inappropriate diuretic hormone problem. And hyper is your diabetes insipidus. Okay? This one, the sodium is more concentrated, so it's going to be high. And over here, it's more diluted, so it's going to be low. And when I say diluted and concentrated, that's in the circulating bloodstream. That's what I'm talking about. Okay, so diabetes insipidus and diabetes, or syndrome of inappropriate antidiuretic hormone. And then this just goes through some causes of it. Again, it's a syndrome, meaning it's caused by something else. So all of these different things that you see here can be a cause, so many different causes of it. This is something that you would deal with in a critical care area. You probably would not have a patient in the places that you're at in clinical right now because we watch them very closely and usually put them in ICU. But again, the signs and symptoms, we already went through all those. The fluid retention, they're going to be gaining weight, low sodium, which we said. And this 135, 145, that was just a reminder what the normal is. And again, low, meaning dangerously low, would be like in the 120s. Okay, so the diagnostics, we're going to do a serum sodium level, obviously. We're going to try to restore the fluid and electrolyte balance. We might give Lasix to get rid of some of that extra fluid that's accumulating in the tissues and not going out of the body. And what Lasix does is it blocks the action of antidiuretic hormone in the kidneys. let's see, we keep head of bed flat, and that also helps for some reason, and I don't know why. Again, these are things that have just been shown to work. Helps decrease ADH levels. We use hypertonic fluids, and I don't know if you guys have gone over the types of fluids yet. No, because you're in second semester. I think third semester skills lab goes over the different types of IV fluids like hypertonic, hypotonic. Have you guys learned about that yet at all?
Yeah, a little bit. Very briefly.
A little bit? Okay, well what hypertonic fluids do, and the reason that we give them in this situation is because hypertonic fluids expand plasma volume when a person has hypovolemia. So, and hypovolemia, so just remember that it's where the fluid is at. So even though the person's retaining fluid, they're retaining it in the wrong place, okay? It's not retained in the circulation. It's retained in the tissues. So they need that hypertonic fluid to pull the fluid back into the circulation. Okay, that's the reason for that. Okay, did I have a question here? Yes. What? No? Okay, okay. Okay, so don't get too involved. Don't be worried too much about the hypovolemia stuff. You'll learn more about that later, but that was your introduction to it. There's reasons why we use normal saline versus D5.5 versus lactated ringers. Okay, it has to do with osmolarity and pulling fluid into the areas it needs to be in. And even though you're puffy and swollen, doesn't mean that you have enough fluid in your circulation. Okay, and so that's what we need to fix. Also, a person with syndrome of inappropriate antidiuretic hormone, again, because they have so much fluid in all the wrong places, we might actually do a fluid restriction to prevent them from taking in more fluid until we're able to get rid of some of the fluid that they have. So, Lasix, fluid restriction, and hypertonic IV fluids is how we would go about fixing. Yes?
It's probably not a good comparison. It just reminded me of like pregnant women. They can have swollen ankles, but still need magnesium for leg cramps because they're not getting them.
Mm-hmm. Yep, absolutely.
Not the same syndrome, but
no. Right. Again, it depends on where the fluid is.
In the wrong places, but
yep.
Still need it in your circulation, so your magnesium can be low.
Yep, absolutely. Post-op patients. You guys are going to do peri-op. You're going to read about peri-op in this section. You might read a little bit about what we call third spacing. After surgery, patients have fluid in all the wrong places. They're puffy, and they look like they have lots of fluid on board, but their urine output is low, their blood pressure is low, because they don't have fluid in the right places. It's not in their circulation where it needs to be. It's in their tissues where we don't want it. Okay, and that's what it is with this process.
So that's when we give like the D5, like the hypertonic.
Yes, hypertonic pulls it back into the circulation where it will increase their blood pressure, improve their sodium. Yeah. Okay. So anyway, it's all about, those two disease processes are all about fluid. Okay. I guess the biggest thing I want you to know on those two is diabetes insipidus, not enough ADH, they're peeing too much, and they have a high sodium. SIADH, they have too much ADH, they're retaining fluid, and they have a low urine output and a low sodium. Okay, moving right along. Anterior pituitary disorders. And you can read through that slide and we'll move right along. So growth hormone deficiencies are the biggest thing with anterior pituitary because usually what is occurring is a decrease or hypofunction of the secretion of growth hormone itself. So again, there's a lot of things that can cause that. And growth hormone, by the way, does a lot more in our bodies than simply make us grow. I don't know if you realize that, but it's not only for growth. But growth hormone actually has a lot to do with our sleep and our circadian rhythms. Most of our growth hormone is secreted during our REM stage of sleep. So if we don't have a good amount of REM sleep, we don't get a lot of good growth hormone secretion. So that's interesting to know. Sleep deprivation can actually deplete your growth hormone secretion. But what growth hormone does, other than just make a person grow, is it helps with increasing calcium retention, helps with muscle mass and protein synthesis. This is just for your information, you guys. You don't have to write this down and remember it. I just want you to be aware that growth hormone does so much more than just growing. It also helps in the liver. It helps to reuptake uptake glucose in the circulating blood, and it also stimulates our immune system. So again, growth hormone is way more important than just for growth itself. But what can go wrong? Well, these things can go wrong. One of the things is what we call gigantism, where excess growth hormone is secreted, and it's a person can get gigantism if it is secreted before the growth plates close. In other words, when the growth plates are closed, and growth plates are found at the end of long bones, by the way. So if a kid breaks their leg at the end of a growth plate when they haven't finished growing, that could stunt their growth. Unfortunately, like one leg could be shorter than the other because they broke their bone at a growth plate. But anyway, if their growth hormone is decreased before their growth plate closes, it can make them keep growing and cause gigantism. So that's one of the problems with hyper growth hormone secretion. There is a medication called Parlodel that is given. Parlodel is actually a Parkinson drug that we'll talk about when we get to the neurological system, but it also is used to slow down the secretion, or not secretion, production of growth hormone. So we can help that with a medication. And then the other process that is good to know that can happen with hyper secretion of growth hormones is what we call acromegaly. Acromegaly is more of an adult problem, and acromegaly is enlargement of bones and connective tissue. A lot of times it's due to some sort of a growth, usually a benign tumor. And so you can read the rest of this, what it says of what acromegaly is, but it's important for nurses to know the questions to ask in order to identify what's actually happening. And one of the questions, again, when we're asking about endocrine disorders, we're asking if there's been any changes, and we ask about weight, and we ask about, energy levels. Something as simple as, and I know it sounds silly, but this is really a good question. Have you had any changes in your shoe size lately, or your ring size, or have you jaw, or, anything, any changes in the size of any part of your body that seems odd to you? Because that's not, a person who had a size 5 shoe and then 2 months later they're wearing a size 8, that's not normal. Okay? So acromegaly, it's a real disease process that can occur, and there's actual symptoms, and something as simple as asking that question, if you had a change in shoe size, can be a red flag that, there's a problem with your endocrine gland. So again, knowing the questions to ask and how to assess for these problems. Okay, and then growth hormone depletion, the opposite end of the spectrum, not enough growth hormone, obviously. The disease process is called dwarfism. Usually the dwarfism is due to hyposecretion during the development of the fetus within the mom's uterus. So before they're even born, there's a decrease in the growth hormone, and it affects the person throughout their whole life. Let's see, and again, you can see it can be a congenital thing, or it can be damage to the pituitary gland. You can read the rest. It shows you what happens with a growth hormone depletion. And then the next page is a picture of acromegaly. And the thing about the shoe size with acromegaly is that's one of the first things that can be noticed a lot of times is that the feet just get horrendously big. I mean, just really large. And that's one of the kind of a red flag is that the shoe size just automatically, whoo, they just grew. Okay, and then one more thing before we're going to do another something else. I want to talk about pituitary tumors briefly. A pituitary tumor is very rare, actually, and they're usually benign, but unfortunately, if you have one, they can cause some major problems. Again, because we know that the pituitary gland is where most of the hormones are secreted. If there's any problems with the secretion, we're going to have some issues. So even a benign tumor can cause some big problems. So you can go through the symptoms here, and one of them is increased intracranial pressure. And I talked a little bit about intracranial pressure earlier, telling you about if we had any problems with trauma or excess swelling on the brain, that it can affect the hypothalamus. Well, the pituitary is very close to the hypothalamus, and so it can also affect the pituitary gland. Intracranial pressure is something that you'll hear over and over again as well in nursing, and anything can increase intracranial pressure. Taking a deep breath and coughing increases your intracranial pressure. Reaching down and picking up your shoe off the floor increases your intracranial pressure. Now, those are normal things, and your body compensates for that very well. But if you have a brain bleed and you're like bleeding on your brain, and your body can't regulate that intracranial pressure on its own, that's when the problems occur. Okay? And some of the symptoms that you will see with intracranial pressure are symptoms of hypoxia, first of all, but neurological changes are number one. A person will start to become confused. Sometimes it's a slow pressure, and sometimes it's a quick pressure, depending on what's causing the pressure. You'll also see one of the red flags to intracranial pressure are changes in the pupils. Okay? Just very briefly, I'm telling you this because you're going to learn more about it later, but you need to know it because it's one of the signs that there could be problems in the endocrine glands, is especially swelling on the brain if there's in the pupils. And what I mean by problems in the pupils is they should be equal and reactive to light. But if you're ever checking a person's pupils and one of them is dilated and fixed, that is indicative of brain damage and pressure on the brain. Okay? Or if one is dilated more than the other and it's very sluggish or weak in reacting, that's a sign of impending intracranial pressure. And so you can, at that point, it can still be hopefully stopped and fixed. But if it's blown, meaning the pupil is totally dilated and there's no reaction at all, that's brain damage. Okay, so again, intracranial pressure. Also, if the person's bleeding, they're going to complain of a headache, pain in their head. So watching for any signs of intracranial pressure. Okay. And going back to what we just talked about with our diabetes insipidus and syndrome of inappropriate diuretic hormone, because they're syndromes caused by other disease processes, pituitary tumors are actually one of those processes that can cause those diseases. Okay? Pituitary tumor, because it's not secreting, this is like answering one of your questions, Tyler, the pituitary gland is got pressure on it, it's not secreting the antidiuretic hormone, so that hormone's not getting the message to the kidney to get rid of the fluid. So this is one of the reasons why that's happening. If they have a pituitary tumor, that might be why it's happening. So, okay. Okay, so anyway, you can read the rest of that, and let's see. Okay, I want to take another break just till 1:30, and then we're going to do one more reflection, and then we'll keep on going.
Alright guys, I hope that helped. I'll get this loaded up to YouTube and put it on the page for you. If you guys have trouble with anything else, just let me know, okay? Alright, have a good one, guys.